Larry, thank you very much. It's indeed an honor and pleasure to be here. This is a program all of us around the world hold in very, very high regard for not only its clinical strengths, but its basic research platform. So for the residents taking notes as they were yesterday, the answer to this question is yes and yes. We are being too aggressive in some patients and not aggressive enough. The data that I will show you is supported by our CAPTURE, it's a National Disease Registry supported by TAP, and my funding from the Department of Defense and the National Cancer Institute. Prostate cancer, as we all know, is a very, very common disease, very, very prevalent around the world. And there's completely no consensus on the benefits and risk of early detection or what constitutes the best form of treatment for any stage of disease. The content for this around this disease has gotten actually more intense rather than less intense. So there's actually in some situations less clarity than there was even 10 years ago. Now, the historical paradigm for prostate cancer has changed dramatically over the last 15 years. 15 years ago, prostate cancer was treated mostly by monotherapy, either radiosurgery. Risk assessment was imprecise and often wrong, so understaging occurred 50% of the time. We didn't have a sensitive biomarker that was highly prevalent until the late 80s, probably not highly utilized until the early 90s. In high-risk patients, hormonal therapy was not advised until symptomatic metastatic disease was present, and chemotherapy and secondary hormonal therapy were felt not only to be morbid, but to be ineffective. Now we have a sensitive but less specific, one would say, biomarker PSA in common use. PSA in the United States is highly prevalent in urban areas. Probably 2/3 of the men have had a PSA done in the last 2 years' time. The natural history and risk assessment for prostate cancer is much more precise. Understaging occurs only 20% of the time, compared to 50% of the time 15 years ago. Combination therapy has proven to be effective in select populations. Early hormonal therapy in high-risk patients appears to be better than delayed hormonal therapy. And as I will show you, secondary hormonal therapy and chemotherapy have been shown to be effective. And obviously, novel therapy is a very, very high priority. Early detection, again, we're racing to screen younger patients at lower PSA cut points, doing more biopsies, detecting smaller cancers, and leading to considerable controversy. This race to biopsy and discover prostate cancer has gained great traction, certainly in the United States, and I would suspect in Canada. Now, where's early detection gotten us? Now, this is, I'm showing you changes in grade over the last decade. So for prostate cancer grade, we see that the number of patients with high-grade cancers is about the same. We see an increasing number of patients with Gleason 3, 4, or 4-3 cancers, Gleason 7, and a decrease in very, very low-grade cancers. Now, this decrease in Gleason score 2 through 4 is not a biological phenomenon. This is simply a product of pathologists grading this disease differently. So there are tutorials online now about grading. So in fact, this grade migration upward is simply a product of different grading schemes. If we look at trends in risk of diagnosis, I showed some of this last night. So the PSA has dropped. The average PSA, the time of diagnosis, has dropped from 12 10 years ago, and we're racing down right close to 4 to 6 right now for the average PSA. T-stage has dropped considerably. The number of patients presenting with metastatic disease at the time of diagnosis has dropped from 2% 20 years ago to around 1 to 2% currently. T3 disease constitutes a very small number of patients that we're currently seeing, less than 8%. And obviously the biggest number of patients we're seeing is T1C or T2A disease. So high-risk patients are those who have either PSAs greater than 20, Gleason 8, 9, or 10, or T3 disease. Low risks are PSAs less than 10, no pattern 4 scores, T1 or T2 disease. So over the last decade, there's a trend towards low-risk disease. The most common cancer currently detected in about 55% of patients is T1C low-grade, low-stage cancer. Very importantly, as I told the residents, even though if we look at risk reduction in high-risk patients from 36% to 16%, very importantly now, it turned out that 10 years ago, people presented with high-grade, high-stage, and high PSA cancers. Currently, the most common high-risk patient is a high-grade, lower PSA, lower T-stage patient. So within risk groups, we've seen migration to a lower-risk disease. Now, what floored people with this race to get to lower PSA cut points is this data from the prostate cancer prevention trial, where men were randomized between finasteride and placebo as a chemopreventive agent. And at the end of this trial, men got a biopsy. So all men, you could get a biopsy if your PSA went over 4 or you developed a palpable nodule. But at the end of the study, they wanted to biopsy everyone. So these are the number of cancers detected in men who non-palpable, so normal DRE, PSAs less than 4. And what floored people, that overall 15% of men with PSAs, so-called in the normal range, were found to have prostate cancer. And about 30% of these would have been thought to be clinically significant based on grade or volume. In fact, there's very little difference between the detection rate for prostate cancer between PSAs 2.5 to 4 and between 4 and 6. So with these results, there is currently in the United States a big move to go ahead and decrease cut points for biopsy, so go from 4 to 2.5. Now what that does, no matter what country that you live in, and I'm sure if I showed Canada it would be the same thing, but if you look at the populations of men, the number of patients, a number of men with PSA between 2 and 4 and greater than 4, what you can see in the country around the world, you will simply double the number of biopsies that are taken. So you'll double the number of patients who will need to undergo biopsy. It has a huge impact on cost. But nevertheless, this is gaining great traction. Now, this was some very nice data from the UK presented at the ASCO conference in San Francisco about 3 months ago. And what they did is they looked at the impact of PSA detection on the heavily screened population of men. And what I'm showing you here is what they modeled for is for low-grade tumors, intermediate-grade tumors, and high-grade tumors, what was the lead time between diagnosis and development of clinically apparent disease, what was the 15-year cause-specific survival without treatment, and what was the survival benefit with treatment. And they found for very low-grade cancers in a heavily screened population now that, in fact, the lead time was 14 years, the impact on mortality was essentially nil, and there appeared to be no survival benefit to immediate treatment. Now, that's not the case for intermediate-grade and high-grade tumors, where the lead times are much shorter and the impact of treatment much more significant. I think the battle for prostate cancer will be won or lost, not on these low-grade, low-volume cancers, but in fact on higher-grade disease. This is where we, in my opinion, we need to concentrate more and more of our efforts. Again, increasing the number of biopsies. If we're looking at the United States today, this again is data from Capture showing, and I'm not showing 2006 here, but if in fact we're migrating from a sextant biopsy scheme to one that incorporates 12 or more. So the standard number of biopsies soon to be will be somewhere between 10 and 12 cores, because you'll increase detection rate 17% going from a sextant scheme to one an extended biopsy scheme. So biopsying more laterally at the apex midgland and along the anterior horn at the apex. Someone in our field, Tom Stamey, who used to be chair at Stanford, published a paper about 3 or 4 years ago that created a great deal of debate when he showed that in contemporary series of patients undergoing radical prostatectomy, absolutely no correlation between serum PSA and tumor volume. A lot of controversy. So I went back to my contemporary series of patients, about 260 men that I operated on about 2 years ago, and in fact looked at the same thing, and we had an R value even lower than Tom Stamey's. There's absolutely no correlation between PSA as a static value and tumor volume for PSAs less than 8 or 10. In fact, PSA as a single standalone value is losing its predictive power except at very high levels. So is PSA dead? The answer is no. There's a race to discover new markers ongoing, I'm sure, here, certainly at UCSF and biotechnology. This is big business for many people. We need to consider more intelligent PSAs, the isoforms, but I think very importantly, you need to look at PSA not as a static value, one point in time, but a series of values. So PSA kinetics before diagnosis or after treatment is a more powerful predictor of biology than, in fact, any single PSA value. And it may be that we'll actually go to less frequent testing. So we'll screen people perhaps a little bit younger, but depending on the value of PSA, go to less frequent screening intervals. Who's the average prostate cancer patient? I showed this last night, but I just want to point out that we've seen a stage migration to the disease, but we're also seeing migration in patient populations. This is data from Capture showing that in the United States, the mean age is 65. There's a clear decrease in the age of diagnosis 15% is some college education. 15% have absolutely no comorbidity. 31% have 3 or more. You need to look at this when you look at your patients. How many comorbid diseases do they have? 25% of normal body mass index. When I saw this, I went to my fellow and said, well, it just shows a big link between obesity and prostate cancer. But this is no different than a man in the United States without prostate cancer. In fact, we only have one state left, I think, that has more than 20% of adult males of normal body mass index. With regard to quality of life, American men have good performance except in sexual health. I'll comment on this towards the end. How good are we at risk assessment? We've gone from an imaging-based paradigm a decade ago, where we use bone scan and CT scan regularly, to one that now that looks at PSA, T-stage, and grade. So imaging, except imaging of the primary, has almost become irrelevant. And we've tracked this over time. The frequency of the use of bone scans and CT scans or MRIs has dropped precipitously over the last decade, correlating with the trends down in PSA and stage. So these are no longer relevant tests for the majority of patients that we diagnosed. It's a waste of resources. Now, one thing I always want to point out, it's common to put people in 3 risk groups: good, intermediate, and high risk, based on PSA, T-stage, and grade. And this is data that we published in the last year showing that it's okay, low-risk patients defined by so-called the D'Amico criteria, PSA is less than 10, low-grade and T-stage disease, their outcomes are almost fairly tightly packed. So I think it's okay to lump those patients. But I think for patients with Gleason 3-4 disease, PSAs between 10 and 15, you need to use a more careful risk assessment scheme, because the outcomes in this group and in the high-risk patients could be quite a broad range. So this is where you need more detail and should not lump patients into these risk groups. I get a little concerned, especially this, I think, is a comment for Tom. I know in the United States, a patient with high-risk disease, based on any criteria, grade, T-stage, and PSA, when they get radiation therapy, get the book thrown at them. They get 2 years of hormonal therapy. They get high-dose radiation to the prostate and nodes. And yet I think a T1C, PSA6, Gleason 8 cancer may not need all that treatment. This is a discussion we have continuously at our tumor board. Now, how well, a very common risk assessment scheme is the nomogram or the Parton tables, and we've looked at both of those to see how well they perform in a population-based study. This is a concordance table here. This is what the nomogram predicts. This is the actual disease-free outcome based on PSA or second treatment. A perfect nomogram or perfect prediction would be right along this green line. And the concordance index for the Parton table or the Catan index is about 0.69 or 0.68. So 2/3 of the time, these nomograms or probability tables actually predict the outcome quite well. But it's consistent that they tend to underestimate recurrence in low-risk patients and overestimate it in high-risk patients. So we see that these nomograms or probability tables perform best right at the mid-portion and tend to lose its discriminatory power at one end or another. We've seen the same thing, again, with the Parton table. So I showed last night that we've come up with another scheme called CAPRA, which is a 10-point scale. It's been published. We have actually validated in radiation patients as well. Very simple to calculate. It gives good discriminatory power, and it has a concordance index as good as anything in the literature to date. Very easy to use. Don't need a calculator or pen and pencil. Now, will we stop with looking at PSA, T-stage, and grade? And the answer is no. We'll incorporate biological markers. This is some genomic data performed by Colin Collins at UCSF, where he showed that, in fact, looking at genomic differences can predict outcome, something called a GEMCAP prediction score. Using these biologics alone, we do as well as a Catan nomogram, and now, in fact, we're incorporating such tools into standard nomograms. So we'll add phenotypic or biological data to standard clinical data and come up with a better prediction tool. Is prostate cancer care changing? The answer is yes. We published this in the JNCI. What amazes me is we actually track trends at 6-month intervals, and I'm amazed at how frequently we'll see a change in prostate cancer treatment over a relatively short interval. Each of these columns represents low, intermediate, and high-risk disease across the late 80s, early 90s, mid-90s, and 99 to 2002. In red is primary hormonal therapy, blue is radical prostatectomy, green is external beam radiation therapy, orange is brachytherapy, and in light blue is active surveillance. The hatched lines represent neoadjuvant or adjuvant hormonal therapy. So what we've seen over the last decade is increasing use of primary hormonal therapy. Hormonal therapy is the only form of treatment, which appears to be reasonable in high-risk patients, but what we're kind of floored by is an increasing utilization of primary hormonal therapy in people with low, intermediate, clinically localized disease. A big increase compared to what it was a decade ago. Radical prostatectomy rates actually dropped by 2002, but as I showed last night, have actually started to pick up again in the United States among all risk categories. Hormonal therapy is heavily prevalent in men undergoing radiation therapy. Look at brachytherapy coming on the scene. If I showed you, again, 2006, you see even more brachytherapy being done. These are trends in the use of hormonal therapy along with radiation over the last decade. The BOLA trial, Tom, if I recall, was published somewhere around here in abstract form, probably the early 90s, and you saw rapid increases in use of hormonal therapy in high-risk patients driven by the fact that combination therapy appeared to be effective. Interestingly, in the early 90s, there was no data on the use of hormonal therapy in intermediate-risk patients, but nevertheless we saw an increase in the use of hormonal therapy in those patients as well, again showing that medical data in one population of patients is frequently drives use in a population of patients that are quite different. It wasn't until here that, in fact, if I recall, Tom, that the first randomized trials showing a benefit to hormonal therapy were actually published. Disturbingly, we saw a very high use of hormonal therapy in low-risk patients undergoing radiation therapy, but interestingly enough, that dropped precipitously about 2 or 3 years ago, which is appropriate. Are we being too aggressive? What about the possibility of doing so-called active surveillance? I don't call it watchful waiting because watchful waiting referred to a different scheme in my mind. The rationale is we've seen considerable stage migration to lower risk disease. We have much more better, more accurate risk assessment. It's clear that it's a protracted natural history for most low-risk patients. This, for the most part, is not precipitously evolving. And I do think surveillance regimens support initial surveillance followed by selective therapy in very well-characterized patients with low-risk disease. Now, I always want to show a word of caution. This is a Scandinavian data that was published many times over the course of the last 15 years. And at 15 years, they saw that the overall cause-specific survival for active surveillance for all stages and grades was quite good at 78%, and the mortality rate was 15%. But when they went back and looked at patients beyond 15 years, they showed a precipitous decline in overall survival. So if you live 15 years, in fact, your mortality rate went up to 44%. Now, I show this because you can't dismiss the idea that prostate cancer can't progress because it progresses. And I think the only issue in my mind is how rapidly it progresses. But this can be a very dangerous disease. Now, evolution of watchful waiting. Now, the old concept was these were very less well-assessed patients. They were usually much more advanced. So in the Scandinavian series, these were patients not picked up by PSA testing, but by TUR, transurethral resection, or physical examination. So they had much higher risk disease than the contemporary patient being diagnosed probably in Canada and the United States. Treatment was delayed until they developed clinically significant symptomatic metastatic disease, and these patients got androgen deprivation therapy. So monitoring was not rigid and was not planned. My idea of active surveillance is patients are very well assessed. We have extended pattern biopsy, we have grading and selective use of imaging. We're diagnosing very early stage disease the vast majority of the time. They're monitored relatively closely. They're treated at the first sign of subclinical progression. So in fact, when we see perturbations in PSA, cancer vium, or grade, then we treat them at a time that their disease is still clinically localized. Treatment is based on risk, and local therapy is tailored. Now, despite stage migration, this data actually floored us. I had an hypothesis that in the early 90s, about 5 years ago, we said because of stage migration, we were going to see an increase in utilization of active surveillance in the United States. That was the hypothesis. We went to the data sets, had the programs look at it. In fact, we treat prostate cancer more aggressively today than we've ever done before. So the rates of active surveillance in the United States peaked in the early 90s and have declined every year since then. So in fact, they continue to decline I am hopeful that with the evolution of new data that in fact we'll see a reversal of these trends to more aggressive treatment. Who undergoes watchful waiting in the United States? Well, obviously it's based on risk. So most people undergoing active surveillance have lower risk disease compared to those that receive active treatment. What predicts for watchful waiting and surveillance? Age. So older patients tend to get active surveillance. Comorbidity, cancer risk group. Insurance status in the United States is a very powerful predictor of treatment. We captured this in Capture. So what kind of insurance you have predicts for treatment. The highest rate of active surveillance assistance. What predicts well for insurance. You need to look at how people are being treated and what predicts for it. Education, ethnicity, or income don't appear to be predict for it, but you always have to be careful. In a lot of our studies that education, ethnicity, and income are very tightly related criteria, as is insurance status. So these are very difficult to sort out what's driving treatment. We find that ethnicity no longer is a big predictor of outcome when you control for education, income, and insurance status. What about low-risk patients? Again, I want to emphasize that for low-risk patients, again, low-grade, low-volume patients, active surveillance has dropped to an all-time low. What actually has taken its place is not surgery. Surgery has actually declined in this group, but in fact, brachytherapy and primary hormonal therapy have kind of rushed on the scene, and these are being more highly utilized. Now, if I ask the question of this group, if you have a 75-year-old patient, PSA 5.0, Gleason 3-3 disease, T1C, what's the best form of treatment? My hope and my sense is most people would say active surveillance. So in fact, we looked at men greater than 75 years or greater in the United States to see how they were being treated. And our hypothesis was that in that group of patients, in fact, we'd see very high utilization of active surveillance. Well, this is the data. So active surveillance for men greater than 75 years of age peaked again in the early 90s at about 52% and have declined every year since then. Now, luckily, we're not doing surgery on them, but we are doing lots of brachytherapy and lots of primary hormonal therapy. So again, even in our most ideal patient population, who we think would be great candidates for active surveillance, we're actually treating them very, very aggressively. This is, again, data from Capture on active surveillance. What's the likelihood of being active surveillance over 5 years' time is tightly related to your risk groups. So low-risk patients are more likely to be treated than patients with intermediate or high-risk disease. Now, this is my own data, and I have on active surveillance about 400 patients. I'm going to show you data on about 352 of those patients. The selection criteria, in my opinion, are patients with low PSAs, no component 4 or 5 disease, less than 33% of the biopsies involved, 50% of any core involved, T2A or T1C disease. This is data from the same selection criteria that Jonathan Epstein identified, a pathologist from Hopkins, that in their series suggested these patients are highly likely to have limited volume organ-confined disease. Now, this selection has to be based on extended pattern biopsy. I can't emphasize enough that you can't accurately assess patients based on a sextant biopsy scheme. Now, it turns out that despite my selection criteria, about 1/3 of these patients are not ideal candidates, that they decided to have active surveillance even though they did not meet all those criteria. So I will show you the data for both of those groups. I didn't change this slide. I changed it in my other one. The overall median progression rate now is approaching 4. The overall follow-up is about 4 years. A little less. I didn't update this one. I updated in my other scheme. A little less in those who have not progressed compared to progression. And these data sets, the follow-up is always lower on those who haven't progressed yet because they just haven't been followed long enough. So the longer you're followed, the more likely you are to progress. And again, our progression criteria is defined by changes in grade to a higher grade disease. So what we do is we follow these men with PSAs at 3 to 4 month intervals. We're heavy utilizers of ultrasound. We do ultrasound at 6-month intervals, repeat biopsy at 1 year's time. PSA velocity has not been a big predictor of outcome because we just find that that's very hard to track. And any change in truss detected tumors volume number. This is the overall data that updated. The overall progression rate in my series is about 22% at 5 years. Interestingly, now that we're getting a little bit longer follow-up on people with, as I told you, about one third of the patients were not ideal candidates. So these were generally lower volume, at least in 3-4 patients. So they had a component of 4, and are not ideal candidates, but they, for one reason or another, were put on active surveillance. And the outcomes of these two groups actually are coming together. In fact, it may be that a low volume, at least in 3-4, will have a protracted natural history as well. So the ideal candidates for active surveillance, we're learning a lot more about this disease. Again, the standard ones, no low volume, no gleason 3 disease. But now what we look at is their PSA criteria when they come in. Nowadays, most patients come to you with many PSAs done in the past. It used to be they'd come in with just one PSA before diagnosis, but now people are screened so heavily, they'll frequently bring in a series of PSAs. And knowing what their PSA velocity is before treatment is a big predictor of requiring treatment. So if I see a patient whose PSA was 1 4 years ago, went 2, 3, 4, 4.55, and was biopsied, that patient's headed to treatment. Compared to a patient whose PSAs was 3.5, 3.7, 3.8, 4.1 over the last 5 years, that patient is a relatively stable PSA kinetic. Free fraction and PSA density are actually also predictors. The Hopkins group, and I think Laura Klotz has shown the same thing. So a PSA density less than 0.15 and a free fraction over 15 to 22% actually tends to predict for non-progression. So low free fractions, high PSA density at the time of diagnosis generally predict someone more likely to progress. Older age, significant comorbidity, and you do have to follow them. I tell patients that I can't guarantee that their cancer can't progress while watching it. We have not seen that, but obviously there's some risk to active surveillance, and our patients need to understand that. If they're not willing to take some risk, then they shouldn't do active surveillance. And about 1 in 20 patients who are doing perfectly on active surveillance get treatment. Like one of my patients said, he says, "Peter, I'm tired of looking over my shoulder every day." They get anxious with it. So it takes a great deal of re-education and support. Actually, for Martin Gleave, we think this active surveillance population is a patient population ideal for clinical trial testing. So right now we have any number of agents we can test on our patients, but what we don't have is large patient populations for testing. So it's very difficult to do trials. So I think in the active surveillance group and the neoadjuvant trials, again, we'll see a great explosion in clinical trial design and testing, because nowadays we can test biologic pathways and mechanisms that can be measured in the tissue. So what we'd like to do is determine whether or not we have agents that have an impact on the prostate cancer microenvironment, not just PSA. So what we're doing now is we're taking these men, again, low-risk patients, we're doing a biopsy, we're putting them on trial, and looking at changes in gene expression. And we have 2 trials ongoing. We have one actually completed. We've done a lot of work on looking at diet and nutrition, and I can tell you right now, 42% of men who undergo treatment for prostate cancer are getting some kind of complementary alternative medication. Could be supplements, could be diet. Those are the most common, but acupuncture, lots of things are happening. And so we did a study with Dean Ornish about a year ago, which was published, which was a randomized trial, again, where we took men who had low-risk prostate cancer. We put them on a low-fat diet, supplement, stress reduction, exercise. It is California, so we have to add a stress reduction exercise. It was a randomized trial, and it was actually a positive trial. So those men who were on this Spartan regimen, in fact, those patients tended to lower their PSAs, and none of them have got treatment. Whereas in those men who were in the control group, those men's PSAs tended to go up. And these were, even though these are small perturbations in PSA, these were statistically significant. What we did is we stored their serum, and we actually sent it to Bill Aronson at UCLA, who grew LinCap cells in their sera. Now, in fact, the sera tended to decrease cell growth in both groups, but more dramatically under those undergoing lifestyle intervention. And the extent of this decrease was actually directly correlated with adherence to this regimen. It turns out in our control group, about 40% of the patients were compliant with the intervention. When you do a study of diet, it's very difficult to do because you can't control for the diets of the control group. So we actually do dietary surveys, and 40% of the control group actually compliant with the dietary regimen, suggesting that the changes we saw may have been more significant, in fact, if we can control intake. So now we have 2 trials at UCSF in these active surveillance. One supported by the DoD, and the expression arrays will be done by June. So I'll know. We took 31 men and we put them on this low-fat diet supplements. We did serial gene expression arrays. That's done. I have a larger study in R01 looking at the impact of lycopene omega-3 fatty acids. It's a randomized trial. We're halfway through. I have 72 patients on this intervention where we randomize them between lycopene omega-3 fatty acids combinations or placebo, do serial gene expression arrays. We biopsy the patients, put them on the trial, rebox them to 3 months, and do another gene expression array. These are nice trials because you could actually, there's a washout period and they go to the next trial. Now, I do think there's an evolution in prostate cancer because what we're seeing is, in fact, with all the serial biopsies and PSA, we're actually starting to see more focal cancers. So at UCSF right now, about 29% of our cancers are single cancers. 10 to 15 years ago, we didn't see that. Only 16% of patients had single cancers at best. So now that's approximately doubled. So prostate cancer is generally a multifocal disease, but at least 1/3 of patients have one single tumor. And actually, if you look at those who have one single tumor and a microfocus elsewhere, that's even a larger number. So potentially at least 1 in 3 patients, at a minimum, may be candidates for focal therapy, ablating just a portion of the prostate, so-called male lumpectomy, if we had accurate imaging systems. And that's our problem right now, that even using our endorectal MRI at 1.5 Tesla, we do reasonably well detecting larger cancers or higher grade cancers, but we miss some cancers, and although we can localize them to a sextant, we probably don't localize them well enough for image-guided therapy. So this is a focus of a lot of attention of ours, because I do think as we perfect these imaging tests, maybe at 3 Tesla, we'll be able to localize these tumors well enough. We certainly have the energy sources, radiofrequency, HIFU, or cryotherapy, where we can take these out. So I do think within the next couple of years, we'll see a resurgence of interest in so-called focal therapy. Hopefully we'll lead that. Well, being aggressive enough, it turns out that about 1 in 3 men who undergo surgery or radiation therapy fail treatment, despite what we thought was a clinically localized disease. Clearly correlated with risk. It's much less likely in low-risk disease, very high for higher risk disease. What happens with these men? Well, again, I think that cancer, when it recurs, is a spectrum of disease like it is at the time of diagnosis. So of these patients who recurred, 10% developed metastases, 17% died. Of those 17% died, 40% died of prostate cancer. So many people who fail radiation or surgery are not dying of disease, but in fact having a prolonged natural history. So we need to concentrate our efforts, I think, on these patients destined to develop metastases, and perhaps hold off a little bit on those who are not. I do think that secondary treatment is needed in these cases to be, I think, more accurately predicted and assessed. Great state time of diagnosis that allows you to determine if a patient may be failing distantly versus locally. Those who are failing locally with significant risk disease could receive radiation with or without hormones. Those who are failing, destined to fail distantly based on a rapid PSA kinetic, deserve systemic therapy early. We've shown that. So early therapy of those who are destined to develop metastases actually improves survival. Not only cost-specific survival, but overall survival. I have no financial relationship with Aventis, but I do need to show this slide that, in fact, it has been shown that chemotherapy in those who failed hormonal therapy improves survival. Now, it's 2.5 months. So a lot of urologists will say, well, it's 2.5 months. It's statistically significant, but not clinically significant. That's you'd be put in jail if you said something about that, about a breast cancer trial. So in fact, this is a significant trial. It was adequately powered. It shows an impact on survival, and men should be offered this. Now, we being aggressive enough, I could show you a lot of data, but I want to just show it on this slide. Adjuvant radiation therapy is of value in those with biochemical recurrence after surgery. Clearly been shown. But looking at population-based studies, only about 30% of men who fail with PSA after surgery appear to be getting treatment. So in fact, it's very common for men who fail after surgery in the United States to be watched. And yet their surgeons or their radiation therapists felt that they needed treatment to begin with, but when they fail, in fact, there's more neutrality, there's more pause to treatment than, in fact, the time of diagnosis. Chemotherapy and secondary hormonal therapy have been shown to be effective. I don't show you the data on secondary hormonal therapy. We don't have randomized trials, but in fact, I think the data is strong enough to suggest that some men would gain benefit from secondary hormonal therapy. But we looked at the records of 150 men who died of prostate cancer, and we looked to see how they were treated before death. Now, in CAPTURE, we get treatment data from physicians, but we also get it from the patients. The patients get questionnaires every 6 months, and they detail their treatments. I think we do a reasonably good job of capturing what kind of treatment they received. And it turned out, this floored me. I'm not talking about hormonal, anti-androgen withdrawal here. I want to see, for those men who died of prostate cancer, how many were offered a second form of systemic therapy, and the answer was only 17%. So 83% of men who were dying of disease were not being offered secondary hormonal therapy or chemotherapy. And my hope is that, in fact, this is an artifact, and now we have we have trials that suggest a benefit. We'll see a much higher proportion of men being offered secondary systemic therapy. Now, this is not an indictment of urologists alone. I think, in fact, many medical oncologists were very slow to offer systemic therapy to men who are failing with distant disease. It's generally pre-approval, and that's why we think that, in fact, we'll see a rapid increase. Now, the hypothesis is we'll see an increase, but I'm not sure that we will see it to the degree that we should see it. So, again, that data was actually done a year and a half ago, so it's pre-approval. The abstracts were out. There's plenty of information on secondary hormonal therapy by that time. I think there was data on mitoxantrone, and mitoxantrone was approved, and prednisone. But I do agree that, in fact, it's my hope that we'll see that number go up. And I think the only issue is how quickly it goes up. And again, to remind the residents or fellows, in CAPTURE, we welcome new projects. We have a CAPTURE Scholars Program. So if there are questions being raised in this presentation or others that, in fact, we can answer in CAPTURE, we work with a lot of people to show these things. I just point this out here, and Martin and Larry may have many different trials to add to this, but in fact, these are phase 3 national trials of various forms of radiation, chemotherapy, biologics that one could enroll our patients to. So I just want to put a plug in for clinical trials. New outcomes being assessed, again, for disease like prostate cancer with a long natural history, a lot of trade-offs between treatments, this issue of quality of life becomes very, very important. And we track quality of life in 16 different domains, and this can be measured very, very well, very, very accurately and in valid way. Now, one of the questions we asked in the late 80s, Mark Litwin was the lead author. Mark Litwin from UCLA was the lead author on this. In CAPTURE, when a patient sees their physician, the physician fills out a little form how well they're doing, what's their leakage and sexual function. We get that. Every 6 months, the patient gets at their home a questionnaire on quality of life. So what we did is we compared the physician's assessment of that patient's quality of life with the patient's assessment of their own quality of life. This was done in the late 80s of a highly circulated patient. Now I'm showing you here 5 different domains: physical function, fatigue, pain, incontinence, and impotence. But I could show you all 16 domains and there'd be no difference. So I'm just showing you 5 as an example. So this is a percent of those patients reporting impairment, either assessed by the patient or the physicians. So this is a physician's assessment in yellow here, the percent of patients reporting significant impairment in one of these domains. These are the patient's assessments of their quality of life. So in fact, this just shows you that when you're looking at quality of life, these should be patient-centered surveys. It's no longer appropriate to have a physician or that physician's nurse assessing outcomes. It has to be with validated instruments. So I said, okay, that was done in 1998. Let's do it all over again. Everyone's done their lesson. The data's been out there. We've circulated. Let's do it again. So last year we did it again. No difference. We haven't published that, but in fact, there's still a big. I don't think it's because physicians are dishonest. I think it's very difficult even for patients to report adverse outcomes to their physicians. So again, the point here is we need to pay more attention to this. It turns out with quality of life, we've shown a lot of things. I think what the take-home messages for me with regard to quality of life is it's important to patients. It should be measured. What's amazing to me is this perception that there are major differences between treatments doesn't appear to be the case. So whether you're treated with radiation or surgery, the total burden appears to be very, very similar. Patients have declines in the first 3 months, come back to baseline, except in the domains of bowel function, urinary function, and we measure function and bother and sexual function. Those tend not to come back to baseline. But the overall differences between treatments are more minimal than you'd think. African American patients have lower quality of life at baseline and over time. They never catch up to Caucasian counterparts. Again, most of our work now is suggesting that these may not be ethnically driven differences, but differences in insurance status, education, and income. When you control for that, ethnicity appears to be dropping out as a predictor. So I think the emphasis for me is full discussion of all options openly and honestly. How we treat the disease today will be different than how we treat it tomorrow. We need to be open to that. We need to characterize risks fully. I'm a big believer in multidisciplinary care. Patients should be seen by surgeons, radiation therapists, medical oncologists for the most part. Continuum of care, by that I mean you not only have to see the patient as they sit in your office today, but how they may sit in your office 3 to 5 years ago. To what extent have you planned for failure should that patient suffer a biochemical recurrence? Clinical trials are a high priority, and again, I don't need to say this here because you already understand this, that further investment in basic and clinical research, translational research, is a high priority. Now, in closing, will prostate cancer become a bigger problem or less of a problem? Well, cancer is going to become a bigger problem. This is data in the United States, but it would be no different in Canada. Tom, correct me if I'm wrong, but in fact, if you look over the last 50 years' time, dramatic decreases in the risk of death due to heart disease and cerebrovascular disease. So major declines in death rates due to these two killers. But overall, cancer death rates have changed very little. So patients are living longer, dying less commonly of cardiovascular disease. Now, a nice article written by June Chan, it was at UCSF. We wrote this article about 1.5 years ago, and what I'm showing you here is breast cancer in women, prostate cancer in men, per age group, and total population here. Now, if we do nothing to prevent this disease, or better treat it, because of the aging population of men and women, we'll see an epidemic of cancer deaths by 2045, by likely 2020. Dramatic increases because of the increase in death rates in the aging population due to, in this case, breast and prostate cancer, but I would think very similar increases in colorectal cancer and other cancers as well. So again, I want to emphasize to the residents, we have to be open-minded. How we treat the disease will be dramatically affected by our investment in basic research. I do think that we will treat prostate cancer very differently over the coming years than we're treating it currently. And lastly, I'd like to thank all the people I work with at UCSF. I have a great group of people that I work with, and I really owe them the thanks for helping me put all this together today. Thank you very much. Yeah. So the question is, did we look in our focality paper, did we look at grade as a predictor of focality? No, we didn't, but we should. And what I'll do is when I get done here, I'll email back to my programmers. It is likely, I think, that in fact lower grade cancers are more likely to be unifocal, but I don't know that. Great question, and we have the data.
And then the second question to that is whether you predict that on biopsy.
Yeah, so can we... Correct. So can we predict that on biopsy? And I think the answer is likely yes. I think right now, because we do the extended pattern biopsies, what we'll do is we'll combine the extended pattern biopsy scheme, placement of the tumor, with imaging. So if we have someone who's had 16 biopsies done, and the biopsies are positive at the right apex and mid-gland, and we see on Doppler ultrasound a lesion at the apex mid-gland, that's probably likely predictive of unifocality. Now, I will admit we might miss a microfocus of disease somewhere else, but that may not be important. We'll treat this disease as a chronic disease and treat the gland selectively. So we'll take out the larger, more biologically important tumor and maybe watch that smaller cancer. There are people now doing biopsies, 100 biopsies through peritoneal template, trying to do, localized